Perfect.
Yes.
Thank you. So welcome everyone to our fortnightly webinars for COVID-19. So we're really excited. We've got an interesting lineup tonight of different talks and different areas we're going to cover just to try and keep these webinars really interesting, which is really exciting. So first of all, I'd like to acknowledge the traditional lands in which we're meeting here this evening and acknowledge the Kaurna people and pay our respects to elders past and present. And what we're going to mix it, just because we're in the mood of mixing things up, we're going to have our guest presenter who's going to be presenting first. I'm going to ask Dr. Tom Dodd to introduce our guest presenter and why we're so excited to have him with us this evening. So thank you, Tom.
Thank you. So good evening, everyone. So we're going to start with a little bit of science. So I'd like to introduce Dr. Xuan Lim. Xuan is a dual qualified infectious disease physician and laboratory microbiologist, virologist, who's, I think, just in the process of also completing a PhD in hepatitis, amongst other things. One of his areas of expertise is in microorganism whole genome sequencing. So he's going to tell us a little bit about what we've been doing in that area with COVID. So if we can get Xuan, who's also online, up, I'll hand straight across to him.
Perfect, thank you, Tom. So we're just going to load up Xuan's presentation.
Hi everyone, can you hear me?
Fabulous, we can hear you from our end. Wonderful.
Yep. I'll try to share my screen.
I think we can see your screen.
Yep, all right.
Perfect.
Perfect.
Yes, the slides are just going to come up now. I'm just going to check your slides are coming up. I think we've got your spare screen on view. How are you going there?
Yeah, good.
Good, excellent. So just while the slides are loading up, we'll just have a bit of a chat while we're waiting. So just who's in the room here, we've got Dr. Louise Spibe, Director of CDCB. Really excited to have Dr. Sonali Veena, who many of you know from general practice, who's been working in CDCB in different areas at SA Health. So we're really excited to hear from her and what she's up to in her role there. We've got Dr. Jenni Goold from the GP assessment team, and also who is the clinical lead of the Shared Care Obstetric Program. So thank you, Jenni. And then Dr. Tom Dodd, who's the Clinical Services Director of SA Pathology, and Dr. Chris Moy, who's with us, who's AMA SA President. How are you going with your slides there?
It is ready. Can you see my screen at all? Or?
We can only see the mountain, and I love mountains. That makes us feel like we're out about on adventures, but I think we just can't see your slides.
Should we try?
So I just think you just need to click on share screen down the bottom there, and you can actually then select your PowerPoint down the very bottom of your screen on share screen.
Down at the bottom.
Yep, and there's a share screen button.
The green icon.
I don't have that for whatever reason.
That's okay. Let's just see.
Is it?
Listen, we might just see when it comes to me and put it on.
That's perfect. We're just seeing some things happening now with PowerPoint at the top of your screen there. And just while that's loading up, I'll just start with some of the Q&A questions as well. So we've had a few emails come through, and it is a beautiful island. Thank you, Naomi, for that. We've had a few emails. So particularly we've had emails around, well, what's happening now with COVID restrictions being eased? How does that impact general practice? So we know the announcement of the COVID Safe Plan is around making sure that businesses that were forced to close or required to close as part of the direction can reopen on the 1st of June as per those current recommendations, and there's a requirement to have a safe plan in place. And so if your business was one that was required to close, perhaps you're working in the cosmetic medicine space and you were required to not operate during this time period, it is really important that you do have a COVID safe plan. It's quite easy to do it online, and it is a requirement, particularly if you are are reopening on the 1st of June. So just keep that in mind. I'll put that in today's update. Some of the other areas we've had some questions on is around our current case here in South Australia. And we've had a few emails on that. So hopefully I was able to answer that a little bit for you today. In terms of, is there, with the new case in SA, will there be a change to exemptions for travel? Thank you for posting that question. So currently the Exemptions Committee is meeting this evening and will be reviewing their processes as per a sort of review panel. But what I really want to emphasise with this is that we've had over 40,000 people have come into South Australia across the borders, with over 23,000 just have come across with on exemptions into South Australia. So that's exemptions as in they're essential travellers. They're not actually applying for the exemption, but they are allowed to come into the state. So it is really important to know that we do have so many safe principles. And I mean, I'm very happy for others in the group. Sonali, you might want to talk about what that sort of means, or Louise, how that means. But it is really important to know that we do have people coming in from overseas and interstate, and there are strict rules in place to ensure the community safety. And really happy with the fact that we have been having now 760 people have come in from overseas, have come into South Australia since the beginning of COVID-19 and the new restrictions. And this is the first positive case that we've had of those people coming in. So we do have strict processes. They are screened at the airport, they're swabbed at the airport, they then go into a hotel for mandated quarantine if they're from overseas. Now, if they've been an interstate, now we know that interstate is in fact swabbing passengers when they arrive at around day 3. If their swab comes back negative, depending on where things are at, then we can also look at whether they're going to come across. And in this case, that particular passenger did have a negative swab in Victoria, then came to South Australia on the basis that they had that negative swab on any compassionate grounds, and then were picked up, thankfully, due to our very strong processes here in South Australia. They were re-swabbed at the airport and were picked up. So really lucky that wasn't an issue. Sorry, the sound is causing problems for you. We're just we've got Schwann's screen up now. Is that right?
No,
yes.
I've got his.
So we're going to just put your presentation up, Schwann, because we just still can't see it. So we've put it up here on our screen here, and we're just going to load that up there. Yep. If you're happy to let us have access, that would be great.
Yeah, that would be great. Yep.
Thank you.
All right, I might just talk through the presentation if that's okay. And if you can click for me to the next slide.
No worries. I'm just going to try to get your just if you can exit out of share, the share screen mode.
How do I pause share?
Yep, that's great. Thank you. And then we should be able to then load up here, just on your share screen.
No,
right.
you're still blocking.
That's okay. So what I'm going to do is put it right. Just to, sorry, apologies for the delay. All right, that should now work. All right, we're just loading that up now. Thanks so much, Chris, for doing that.
Oh, excellent.
Perfect. So we can see your presentation now, which is great. So we'll let you take the reins. We'll just mute ourselves here so we're not causing any problems. Thank you.
Yep. Thanks, Crystal. If you can move on to the next slide, that would be great. Yep. So during a viral outbreak, I'm just going to briefly talk about the whole genome sequencing of SARS CoV2. So during a viral outbreak, the public health laboratories play a central role in assisting the Department of Health in control of disease. So in SA Pathology, we actually look at 4 essential testing areas that will provide both immediate and second stage response to the control of SARS CoV2. So we first developed highly sensitive nucleic acid testing, followed by rapid tests to assist the detection of SARS CoV2 in vulnerable communities. And then subsequently, we're developing the viral sequencing to assist with contact tracing. And now we're looking at antibody testing to determine if infected patients do develop protective immunity in anticipation of potential viral resurgence. Could you move on to the next slide, please? Thank you. So here in we have developed a protocol and bioinformatics pipeline to use next generation sequencing technique to sequence the whole viral genome directly from swabs. So first instance, the virus from nasal swabs are first inactivated by total RNA extraction, and that's followed by a process of reverse transcription to produce complementary DNA called cDNA. So this is followed by a selective enrichment for the SARS CoV2 viral cDNA using a multiplex PCR. And then subsequently, this viral cDNA is put through a whole host process of library preparation steps that will help to barcode all these DNA fragments. And these samples eventually would be pulled together and then put through to a high throughput sequencer. So the sequences produced in small fragments, and they're aligned with a reference viral genome to get the complete SARS-CoV-2 sequence. And all the nucleotides labeled blue here are the consensus sequence from all these DNA fragments. So the whole genome sequencing of SARS-CoV-2 is actually a very high throughput method. We can sequence a large number of viruses within a very short time, and it produces much faster results than traditional sequencing methods. It also bypasses the need for using viral culture, and therefore is much safer and doesn't require physical containment through laboratory. And it also produces higher quality data, but does require scientists very highly skilled in bioinformatics. So next slide. So if you can click once, please. Could you click on the, yep. So here, thank you. So these are a few examples of the clusters first identified in South Australia. So the sequencing clusters shows that the genomic clusters have exact matches with the epidemiologic clusters, which are indicated in the same colors as either red, green, or blue. If you can click for the next image, thank you. So as part of the International SARS-CoV-2 Sequencing Consortium, we can add our sequences to the international database such as GSAID to identify the geographical locations of these clusters. So the South Australian clusters are the mid blue, bigger round circles as shown here. They all across different clades and indicating the original geographical location for all different countries. If you can click on the next image, please. So this picture shows our contribution in SA Pathology, in which we have contributed more than 20% of a complete SARS-CoV-2 genome sequences in Australia. So therefore contributing quite significantly to the genomic information of this virus. Next slide, please. So this slide shows how whole genome sequencing can help with our public health response. So in the early outbreaks, whole genome sequencing of SARS-CoV-2 can identify missing links or common source of infection, and therefore expediting contact tracing and preventing further transmission. It can also prove the lack of connection between clusters and also identify potential hospital hotspots or location of transmission. If you can click on the image again. So now that we are moving towards the second stage of public health control, whole genome sequencing can help us monitor viral evolution in real time. And this is very important in identifying the emergence of highly transmissible strains or highly virulent strains. And also in anticipation with the arrival of new therapies and vaccines, so we can use whole genome sequencing to identify any emerging drug resistance or vaccine escape strains, and therefore help guide the development of new therapies or vaccines. But most importantly, by adopting this technology, we're able to develop whole genome sequencing expertise in South Australia, and also safeguard our future for any potential infectious diseases or viral outbreaks. Next slide, please. So our next move is to sequence all SARS-CoV-2 samples in South Australia to give a more complete picture of the epidemiologic connections and investigate undetermined clusters. Interestingly, here we also found that whole genome sequencing method that we're using is very sensitive, and we could potentially use this to confirm equivocal PCR results. So we are also in the process of assessing a pan-viral probe captured whole genome sequencing method, which could be very useful in identifying novel viruses. And also one example of its applicability would be in patients with meningoencephalitis with negative CSF PCR results, and also extending this application to assessing drug resistance in blood-borne viruses. Next slide, please. So this is my last slide. I just want to acknowledge all the people who actually contributed to the development, but in particular, Dr. Lex Leong, who is the senior genomic scientist who single-handedly developed this pipeline of bioinformatics and also the viral sequencing. Thank you very much.
Thank you so much for that presentation. I think we've all been really interested in this space and what the future holds in terms of whole genome sequencing and where we see this playing out over the next few years. So thank you so much for that very informative presentation. Hopefully I'll stop getting as many questions now in genome sequencing, which I definitely cannot answer. So I'm going to hand over now to Dr. Louise Flood, who's going to give us an update from a CDCB perspective. Thank you, Louise.
Hello everyone. So I've just got standard epidemiology update really. So just the number of cases as of yesterday, over almost 5.5 million cases, with the largest number occurring in US, and then large numbers in those other groups, other places, particularly Russia, Brazil, UK, Spain, Italy and Germany. And as I've said, almost every time I've presented this, all the cases that are detected depends on who you're testing and how you're classifying your cases. So they're likely to be underestimates if you're, well, large underestimates if you're only testing people who present to hospital. And 346,000 deaths, with most of those deaths being in the countries listed there. So USA, UK, Italy, Spain, France. The case fatality rate is now sitting at about 6.4, so that does change slightly, and again, it is affected by who you're testing. So just looking at the curves there, Australia is still relatively flat curve now that, and so this is just the number of cases since we first got to 100 cases. No, number of days since we first got to 100 cases. But you can see some are quite steep. So USA, Russia, but we're still relatively flat there, which is good. Looking at the epidemic curve again until the 25th of May. There's still large numbers of cases in Americas, but you can see the Eastern European areas sort of increased a little compared with what it was a few weeks ago. And you can also see that increase that has occurred there in the Southeast Asia that's now picking up. And part of this will be related to testing. As I've mentioned a lot of times, testing, how you test really affects what results, how many cases you have as a confirmed case. Looking there at the number of cases in South Australia, in Australia, in Australia so far we've had over 7,000 cases. A large portion of those have all recovered, 102 deaths. The majority of cases are overseas acquired, but we do have also a reasonable portion who are locally acquired with the contact of a confirmed case. And now there are the 617 who are locally acquired with a contact not identified, and 113 who have travelled interstate and haven't identified unknown contact. And small numbers under investigation. And looking at the newly acquired cases, it's over the past 24 hours is 15, and changes over the last 72 hours is 28. So we're still continuing to get trickles of cases, but compared with what we were getting, you know, a few months ago, it's a lot less. Looking there at the epidemic curve up to 26th of May, and you can see that we are continuing to get cases there, but it's still a lot lower than what we were getting in mid-March. And this is the cases for South Australia. We're now at 440 cases because we just had one over the last few days that's already been discussed. 301 of our cases are overseas acquired, 124 contact of a known case, and just the 9 where we haven't been able to identify the contact, and they haven't travelled interstate. So we don't have any currently under investigation. But when we do have that whole genome sequencing, that may result in some alteration in that, but that's yet to be seen, depending on when we've got those results and had a chance to discuss that with our epidemiology team. Just looking at our cases by the epidemic curve, and you can just see that one case that is on there now, and apart from that, haven't had any cases for quite some time. Age and sex distribution, only very small numbers in children, and fairly equal male and female distribution in most of the age groups. And just that reminder, which I probably think almost all of the speakers will mention, which is that reminder that to test anybody who presents with an acute respiratory infection, unexplained fever, and acute loss of sense of smell or altered sense of taste, and that's really, really important. We're particularly trying to want to make, even though we have had a lot of testing, which Tom will tell you about our current numbers, it's still really important to encourage that testing. If you're unable to do the testing in your practice for whatever reason, send the patients to one of the drive-through clinics or one of the COVID clinics so that they can get tested. Really, really important. And that's because that's the way we will detect if we are having other cases. So there's no current outbreak areas in South Australia, and just a reminder, it's still a notifiable condition. Thank you.
Thank you, Louise. And we'll hand over now to Dr. Tom Dodd to give us an update on testing. You've been very busy, Tom. You're still doing lots of tests at SA Pathology. We're not stopping by any means, are we, or cutting back?
No,
it seems to be continuing.
Far from it. So I just wanted to take the opportunity to thank Schwan for his presentation. It's a glimpse into the way in which a lot of microbiology testing will go into the future using whole genome sequencing. It's a very powerful tool. So testing continues at strength, which is very pleasing. This is May, so we haven't seen a drop really in testing numbers. We've had a couple of the busiest days in the last couple of weeks. 1,700 tests yesterday, so it's very pleasing. People are obviously presenting and you folks are referring patients for testing. It's got this sort of cyclical thing every weekend. It drops down, which is a reflection of the fact that general practitioners are actually getting a little bit of time and not referring so many patients, but the rest of the time we're getting a lot of referrals through. I'd remind you that there are now more drive-throughs. So SA Pathology have got R2, but Adelaide Australian Clinical Labs have got some drive-throughs, and so have ClinPath. So, you know, take advantage of what's available near where your patients live. It's a whole of health response, and the private folks are very important as well. So that's where we're at with testing. I'll also just mention a couple of other things that we've got in place to support general practice. I've been promising this for a few weeks, we now have our electronic request form delivery available. So you're able to write a pathology request form for any test and basically put it into a drop box on your computer, and it will magically be available at any SA Pathology collection centre when your patient shows up to have their blood test done. It's been tested and I'm told it works well. So we're now in a position to roll that out, and I guess your practice managers can make contact with us about getting that set up for you. So I hope that's helpful for you. The other thing is we are also opening in the next few days another collection centre specifically for vulnerable patients in Mile End, which I hope will be helpful for selected groups of patients who have sort of booked attendance where they've got various suppression or other reasons why they don't want to be sort of generally mixing with the population. The last thing I just wanted to mention in terms of testing was it's probably good for you all to be aware, we've now got some heightened surveillance testing going for certain groups of the population. We've swabbed a lot of homeless people in Adelaide now. We've got some collections beginning to commence for truck drivers. So I've got a truckie stop about to set up tomorrow in Bordertown, and we're having ongoing discussions to move towards essentially screening all people entering the prison system. So I think all these will be additional safety measures for the community going forward.
Thanks, Tom. Now, I will ask you, so how does this work in terms of your testing for the drive-through testing clinics with this new electronic system? Or is it still the case that we're using the SMS service that you've set up a couple of weeks ago? Yeah, so
really not too much change in terms of the drive-throughs for COVID swabs, but this was really more about supporting, I guess, people, general practitioners who are working away from their clinic, so you can, basically order your pathology test, any test,
yes,
remotely if you're not seeing patients face to face. Although I anticipate most of you are getting back to what looks like more conventional medicine, seeing your patients in your rooms, which is a good thing.
Thank you, Tom, for that. And actually, while you brought up around surveillance testing and where that's all at, I might just ask Sonali or Louise if you want to give a bit of a comment about where that's all at in terms of what GPs can expect to hear from their patients, perhaps the community who may have been screened. So as Tom just alluded to, have been screening vulnerable groups, Tom, those sleeping rough in around as part of the Whitmore Square screening project, which has been through West Care, SA Pathology, and through that surveillance plan. But I don't know, Louise or Sonali, whether you want to comment on the surveillance plan, what GPs can expect in this space.
Yeah, I guess one of the important roles GPs play in putting the request in the lab request form is if within brackets or somewhere in there, besides the clinical features, if the occupation of the person can be put. I think it will have two roles. One is when we read the positive results at CDC, we do look at the clinical features and whatever is on the request form. So the occupation is there, then it does help us to identify, it may help us to identify the clusters earlier than later, because the risk assessment itself takes a lot of time, and if we see the occupation, it helps that way. Yeah. And yes, as you said, with surveillance, I think in future it will help us to identify the high-risk groups as well. So it's always a good idea, good practice to put the occupation, if they're healthcare workers, if they are in from aged care or anywhere to highlight that that's a high-risk group.
And one of the questions we've had come through is around GPs and healthcare workers, exactly as you just alluded to. Is there a plan at all to test GPs or frontline healthcare workers as part of the plan at all?
I think the exact groups that are going to be tested, so as I mentioned before, we're still recommending testing in anyone who has symptoms. And that is still the main thrust of the surveillance plan, is really identifying people who have symptoms and also identifying people who have symptoms in that they may not have actively sought testing, so trying to encourage certain groups to get tested even though they could be tested anyway as part of the population because they've got symptoms. But as far as testing in asymptomatic people, some of the groups have been, one of the groups mentioned is healthcare workers, but exactly how that will be rolled out and exactly which groups, it may just be certain areas such as, you know, in ICU or something like that. As in, that is to be determined.
Yeah, so we're not currently out swabbing GPs at all the ways, or no?
That's correct, unless you have symptoms, and just that encourage you, if you do have symptoms, get yourself tested, and you shouldn't be at work whilst you have symptoms of COVID-like symptoms I'm talking.
Yes.
Just make a comment. My understanding is Victoria taking an attack of testing everybody asymptomatically at the moment, which is kind of a different tack. But I mean, I think my understanding is our strategy in South Australia to go for the symptomatic is far more aligned with probably the national sort of strategy, which is kind of, they seem to be catching up on their numbers, but their numbers are actually based on a lot of this mass hits asymptomatic at the moment. It's kind of an interesting way to go, but there is a slight difference in strategy in different states.
Yeah, so I mean, it's from the CDNA guidelines, the priority is definitely symptomatic people. But various states are doing some testing more broadly in asymptomatic groups. We are considering doing that, but really quite targeted, particularly groups that we're concerned might be at risk for a particular reason, such as with the truck drivers. The concern is that they do interstate travel, and so that may have acquired that interstate, and that there are various exemptions for truck drivers, so that everyone can get their food and all that sort of thing, so that there are exemptions in place for transport, certain members, people and in the transport industry. And so that's why we've got them as a group that is being tested. With people who are homeless, that is because that group may not be tested otherwise. And so that's really how we've chosen some of those risk groups, and things like healthcare and aged care. It's because if that person gets unwell and it is undetected, they have so many more people that they can spread that to. But the exact groups, we're still working with the various industries about that, and so it's in progress. But just to be clear, that, as I think I've already said, the main focus of it is people with symptoms.
Thank you. And we have had a question around, is this sort of population-based sampling like the census? It doesn't sound like that from what you're saying, Louise. It does sound very targeted to those more at-risk groups.
That's right. I mean, it is quite a various aspects are being considered in the plan. So, the asymptomatic testing is in sort of targeted groups. So it's not sort of population wide. It's people who are in high risk professions, really. Well, not high. I'm just saying the professions that for some reason have been identified as needing to be tested. And that may, we may do sampling in that for a while, and then it might be a different group that we look at. So it may change as the disease, just because we're testing people who are homeless at the moment doesn't mean that will be a group that we're looking at later. It may change to make sure that we're not, and it's missing particular groups. And that's really what the whole thing is about, making sure, because we're looking for that needle in the haystack here. That's what everyone's talking about. We're wanting to make sure that we're not missing big groups and we don't end up with a cluster, a big increase in cases occurring because we missed a certain area, a certain group. And so that's what the plan is looking at, trying to make sure that we're not missing groups where it could be spreading undetected.
So Holly's posted a really good question. Holly, one of our country GPs, around, if an asymptomatic truck driver turns up to see me tomorrow, do I swab him? And do I consider wearing PPE considering he's asymptomatic? So I guess it's around sort of what the role of GPs is supporting your plan around surveillance screening.
So, I mean, the screening is mainly been doing for the truck drivers is being done through Tom's organising that, rather than it being recommending it in any truck driver that turns up.
However, serendipitously, if you have someone come in I'd be inclined to swab them. And I think we should all wear PPE when we're taking swabs.
And I think that's a really good point as well that Sonali made. You know, you write that occupation down in the
Yes.
form as well. So if you have someone coming in who is in one of those at-risk groups and you are concerned potentially, you know, maybe they've come in themselves, they've been in a higher risk area, maybe in Western Sydney or somewhere like that, they've rocked up and they're concerned, then I think that is a reasonable thing to discuss that risk with them. But I mean, we are certainly still focusing on the symptomatic testing and being mindful that we are following those. If we are testing asymptomatic, we are following the population health CDCB advice, which is not to just be going out screening everyone in the population who doesn't fit into those categories. I think we agree with that. We're focusing on those high risk groups. And putting the occupation on the form is so important. And Sonali and I were talking about this earlier as well around aged care facilities as well and the impact of any sort of group. So, you know, if you're saying it's, you know, a baggage handler, for instance, that you would put that on the form. And then when you see that maybe there's a couple of baggage handlers coming through, you think, hold it a minute, all your alarm bells go off. And I think that was something really good that you raised as well earlier, Sonali, around that.
We have a cluster in Victoria, we all know was the meat industry. Yeah. So, yeah, as you all know, we in other jurisdictions we had a cluster outbreak of COVID-19 in meat industry. So, I think that small step of putting in the request form of the occupation, we can then it can be highlighted early that this is coming from a certain occupation group, and we can contain it earlier.
Just one other thing one area we haven't really mentioned yet is in aged care. If you have any of your residents get unwell in aged care with an illness that could be compatible with COVID, please make sure they get tested quickly. It's really important if we detect any cases in aged care very quickly because we don't want to have an outbreak occurring there. And so that's, yeah, really encourage you to test anybody who's unwell at all with COVID-like symptoms in aged care.
Yeah, and also just to note, there are domiciliary services to support getting swabs done as well. So if that makes it easier to arrange a swab for one of your aged care patients, to make use of it.
And we have been working busily about how we would manage an outbreak in aged care, and we're expecting some flowcharts in that regarding that to be available very soon.
Yeah, and I think that is really important. Any symptoms at all in your aged care residents, just the slightest thing starting, you know, they say they've got a sore throat. And I think that is really important that you do think about calling up SA Pathology or ClinPath and getting that domiciliary testing happening so that you can get those patients tested. And it is really important if you are going to test someone in an aged care facility, first of all, you write that on the form that they're from an aged care facility, because often their address on Grand Junction Road or wherever they may not resonate at first glance of where they are. And then the other thing to also keep in mind is that they need to be isolated while you are waiting for that result to come back. And we know that from what Tom's been saying, the testing time is really very acceptable in this stage, that it's perfectly reasonable that you would isolate that patient. And all residential aged care facilities do have plans in place. This is part of their accreditation requirements, that they need to have plans in place for infection control. So please don't feel like, oh, I don't want to test it, I don't want to put the burden on the staff. You know, there's only 2 RNs throughout that facility. I think it is really important to keep in mind that we need to be testing just those small symptoms. And, you know, we have been talking about this here at SA Health through some of our meetings around formulating these plans for aged care facilities, that in fact, we are giving exemptions to people coming in. These are from interstate exemptions who have come in for end-of-life care at residential aged care facilities. So we are still seeing that traffic now coming into the facilities. They're open again for those couple of hours a day for up to two people to come and visit one of those residents there. So it is really important that we do take into account these are high-risk facilities, and we do need to be swabbing just the slightest of symptoms. So very important to keep that in mind.
And sorry, just wanted to add one more thing. And if you do have, a couple of residents in your in an aged care facility that are unwell, such that you think there might be something, an outbreak going on, please let CDCB know, even if you don't have any, you don't have your positively yet. But, we would like to know if you think there could be, if there's more than one occurring, even if it's not confirmed as COVID, so that we can be considering whether we need to do anything in response to that.
And we've had a question come through for you, Tom, around, once restrictions become less stringent, do we expect that testing will decrease in that time, or do you think it will increase? What are your sort of modelling predictions thinking with those easing of restrictions?
I anticipate over winter we will do more and more and more testing, and that's what I'd like to see happen.
And absolutely, that's what we want as well, don't we, really, for our state to feel really confident. And just want to put out there again, it's physical distancing now instead of social distancing. That new terminology is coming now. So just re-emphasising that 1.5 metres. So I'm going to hand over now to Dr. Jenni Goold, who's going to give us a bit of an update from the GP assessment team. You haven't been seeing as many patients lately, Jenni, but you've been busy, very busy in other areas. So we'd love to hear about what you've been up to and some of the areas tonight.
Thanks, Emily. Hello, everyone. I think you're going to hear this as Louise predicted from us all tonight. My message is keep testing. And what's the saying? More is less, or less is more. But anyway, we need more. I have heard from patients and some GPs saying, oh, you know, people are presenting with some mild respiratory illness. It can't be COVID. We haven't got any around, so I haven't gone for a test, or I didn't bother to test. It's really important that we just keep on testing. So that's just to reiterate the message that probably everyone's going to tell you tonight. So as Emily said, we haven't seen very many cases. In fact, only one in the last, 20-something days, isn't it?
17 days.
17 days. Okay, so I guess my focus this evening was really just to talk predominantly around life after COVID, or being COVID positive, really. So there's two groups, or there's two things that stand out as really the residual effects after a COVID illness, and that's the physical symptoms that a number of patients continue to experience, and then the mental health issues. And in most cases, it's probably a combination of the two. So the physical symptoms, there's, you know, often the post-viral kind of syndrome that we're very familiar with seeing in general practice and managing, and then there's also a small number of patients that I've been involved with who've really struggled, and further investigation has shown that they've developed some, interstitial lung disease or some more severe consequences of their COVID-19 illness. So I think it's really important when we're managing these people that we are actually seeing them face to face, and we're doing a physical examination in people who've got residual symptoms once they've been cleared from isolation. Pulmonary lung function tests are back, so that makes investigating these people a little bit easier, and obviously if they've got reversible airways disease, we manage that as we would normally. Thinking about the mental health aspect of this, I think this is an ongoing issue which we'll sadly probably see more and more of. And GPs are very well placed for managing mental health. This is part of our bread and butter, really. So obviously assessing these people as you would normally. Care plans are available, medication if you feel that's warranted, and just the usual treatment strategies. I think if you're having difficulty with following up any of these patients, either from physical symptoms point of view or mental health or a combination thereof, there are a number of services available regarding mental health. And I think Emily's daily update had the link to those, and the SA government website has the link. But there's a number of phone contacts, a COVID mental health support line, which is staffed by lifeline counsellors who've been trained around mental health. There are specific services for peer support, talking to someone who's also experienced the illness. There's Aboriginal and Torres Strait Islander services. So there's a number of phone supports, but these are with counsellors or volunteers, so they're not with health professionals. So that's where the GP plays a crucial role. So if you're getting stuck, or patients are getting stuck, and please sing out, Emily and I would happily point you in the right direction of where you can access these supports. for either mental health or physical residual symptoms. So I think the message is keep testing, certainly see our patients face to face once they're cleared, and as a development to our community pathways, which involves my GP assessment team and the MRU or the surveillance unit, we are now going to contact patients at day 7 post-release from isolation, just to do a phone call to check in on how they're going from a physical point of view as well as a mental health point of view. So that's another added in check, which then if there's any issues identified will be obviously communicated to you guys as the usual GPs. So thank you.
Thanks, Jenni, for that. I think that's a wonderful initiative to be calling it the day 7 point, because certainly I know, it's quite a lot of anxiety out there, and certainly as GPs, we want to make sure that you know that there is support available for your patients, and you can get that support through the COVID-19 mental health support line as well, and refer your patients to that service. They don't actually have to be positive to be referred to that service. Anyone can be referred to that mental health support service around COVID-related issues, and particularly with isolation. It's really important to think about everyone's mental health. So I'm going to hand over now to Dr. Chris Moy, who's going to give us a bit of an update about something really exciting, Chris.
So yeah.
Oh, no pressure, Chris, no pressure.
No, this has been.
It is very exciting.
This is going to happen. So look, we've discussed this before. So far until now, we've had those interim arrangements or special exemptions for the prescriptions, which has obviously been a patch-up job to get us over the line. So as of the end of this month, and I think that I just checked yesterday, and it's still looking like we're going to start from that day. There's going to be, and this is important, there's going to be the gradual rollout of the true e-prescribing from 30th of May. So from that date, you will be able to finally do this. And I'll explain a little bit about what it is, but can I point you to this website, look it up, the Australian Digital Health Agency, which has a lot of the information which you're going to need. But essentially what's going to happen, and I think I have said this before, as of the 30th of May, the introduction of this token model will be what is introduced first. So what will happen is that you will basically be able to make a prescription from your computer at work, or if you've got remote access by remote access, you'll be able to then, if you have their email, the patient's email address or the SMS, be able to send them an electronic token, which will basically be a QR type sort of barcode. It will have very limited information on there, essentially just the medication and the dosage. It won't have any other information from identification purposes, mainly from a security point of view, just in case it gets sent to the wrong person. That will be the patient's prescription. Essentially what they can do, the patient can do then is they can either forward it to the chemist by forward emailing the token, or they can take their phone down to the chemist, and the chemist can use a scanner to scan their phone, their QR code, and then that triggers the prescription. The token is not in fact the prescription, but it's the link to the prescription for the pharmacist. So that will be gradually rolled out from the 30th of May. Now it will be scary for some, and just be reassured that for patients who still want paper, you can still go to paper, but you can't have both. You've got to have paper or the electronic token. The electronic token will be somewhat clunky in the first instance, in that for every medication, there'll be a separate token. So that's going to be one issue. But it'll be the first step. And, for people with minimal medications, that will be pretty easy. For some with a lot, may be somewhat more difficult. When the patient goes to the pharmacy and the token's being scanned and the prescription's been dispensed, the patient will get a repeat token, which will be the ongoing medications. That's how the system will work. There will also be, now people have asked a whole number of questions about the fact that, first up, if the screen's broken, that sort of thing, yeah, there may be issues with scanning it, but there's issues with reading our scripts now, so let's just get that perspective. And the other thing is that they can still forward it by email to the pharmacy if the screen's broken. The thing for this to work though is that in the first stages, I can predict that there will be frustration, because the thing that will happen will be that the pharmacists aren't ready, you might be ready, they might not be ready, or the other way around, or the patient can't handle this initial stage of the token. So we just have to go through a teething stage. So don't get too frustrated. I've been down the line with a lot of these things, and you just got to hold your nerve and get through it, and understand it will be a bit difficult at the start. There's a few checklist things which I'll go through in a second, but I will just talk to you about where we will be heading, which is probably going to be the sort of better backup option in the future, will be the active script list model. So in effect, what will happen is you will be writing a prescription on your computer again. It'll go up to the cloud, and it will basically exist as a list of medications which will sit up there and be live. The patient can then identify themselves to the pharmacy by whatever means, which is Medicare card and some other form of identification. And then the pharmacist will be able to link into this active script, see that there's some prescriptions being prescribed by you, and then be able to dispense the medication. This will have some advantages in the fact that there'll be no need for any barcodes or whatever. There'll also be probably a better oversight of the ongoing medications, and certainly be easier to manage multiple medications. But that'll be the later in the year type option, which will come into being.
So Chris, has this been passed through the legislation? Or
there's still some little hiccups to go, as my understanding, but hopefully it'll be just about to happen. But in terms of actual rollout for us, I think we're pretty much there at this stage. I think speaking to Louise, I better double check with, sorry, speaking to Naomi, better just double check again, but I think they're trying to rush this through at the moment to get it going.
And just a few questions have come in, so I'll just ask you if that's all right, Chris, around how do you sort of safely email patients within current privacy guidelines? Do you have any suggestions around how they can send this to the patient token?
Yeah, well, look, that's one of the issues. The thing to keep in mind is because there's no identifying information on there, and there's no, nobody's going to be able to scan it and actually get determine who it is. That's why there's no information on the token. That's the reason. And that's a problem in some ways, because it's harder to kind of, you don't get the script telling you how often it's taken and who it is and all that sort of thing. All there is a little QI code with amoxicillin 500 milligrams on top of it and nothing else. So there is a bit of an issue with that, but the protection is the lack of information on the token. Yeah. But there are issues, and this gets back to the issue about preparing for electronic prescriptions. And this is kind of a checklist which is at that website. But the main things are to make sure that those linked to the My Health Record and most other systems with the identifiers, you're under control. You need to make sure you're connected to the prescription delivery service via the prescription exchange service. So essentially, most of you are. If you're getting a barcode on your script, you're pretty much likely to, because you're going to be linked to ERX or MediSecure, but I would double check it. You will need the latest version of the software when it comes out. So that is something that some people will find a bit daunting and a bit brave, getting an update software on day one, but you will need to do that. The other thing is that I would be strongly suggesting to you that you really start to don't do it without checking with your patients that they know that they're going to a pharmacy that is going to be linked to this, because it's going to be terribly disappointed if they turn up at a pharmacy that isn't ready for this. So my feeling would be to put the word out. Now, certainly in some places where, particularly maybe out in country areas, if you've got a known pharmacy, that's going to be a lot easier. You'll be able to check that. But for some of us in town, that's going to be a bit more of an issue, and we're going to have to spread the word out to teach our patients to check with the pharmacists. And I think that's going to be important, because we have to have three things working here: the doctor's side, the patient's side, and the pharmacy side for this to work. So look, it's going to be a little bit clunky on day one, but what isn't on day one? And it's pretty exciting if you look at it in the long term. We're trying to ditch that stupid paper, for God's sakes. That's a good thing, not a bad thing.
So, Chris, we've had a question around repeats. How do repeats work with e-scripts as well?
So the repeats will be a token. So the token, under the token thing, the first token will go in. and they'll be reissued with another token, which will be the repeats. The active script list will be different because it'll just be sitting there and it'll be ticked off as it goes along. So that'll be later in the year. That will be better, I think, in the end. But this is another option. It's really super convenient for people, especially the other side of town, and they don't need to come around. It's going to be fantastic just to be able to flick a script there.
Will you do the quality description?
Yeah, it's pretty much, as I understand it, it will be. Yeah.
And a question around, what about patients who don't have a smartphone, Chris? Is there any
No.
way for them to receive it?
Oh, by email. They can get it by email, and they'll have to print it out on paper. So they'll be printing it out by paper then. So you can email it to the home address, and if they've got a printer, they can print it out. So in fact, some people who are going to have, say, 5 medications, they're going to have 5 different tokens. The simpler way may be able to get the tokens together and actually print them out in one go and hand that over, rather than actually taking your phone and have to have each one scanned. You just hand the whole thing over to the pharmacy. Look, it's another option to what we've got at the moment. And I know a lot of people would go, gee, why would we do it at the moment? Well, we've had all the complaints about keeping the scripts and the faxing, and now we've got the issues and we've always had issues with legibility and all those things. So before you get too worked up about it, just remember what it is that we've been through so far, and just understand we are going to go through a teething problems in the first stage, and work with the pharmacists. This is a great time to. I actually think that the bigger problems are going to be at the pharmacy end, and I feel quite sorry for them really in this world at the moment.
And we've had a question around, is there any pharmacy guild or other listing of e-script pharmacies? Anything that you know of happening in this space, Chris?
Listing other forms?
Like listing which would be eligible pharmacies that would take e-scripts?
No, I don't think so. But look, my understanding, I actually sat in on a pharmacy. Look, it looks like everybody's going to do it. If they don't do this, they're pretty much going to be on the outer. It's going to happen. It's going to be extremely difficult for them not to do it. But we just need to cut them some slack in that first stage, I think, and work with them in that. I suspect it's going to take a couple of months to get into this token model, and then by the end of the year, when we go into active lists, it'll be much more seamless. But no.
I think we've had a comment around confusing. How confusing will this token prescribing be? I think it will be a little bit to get everyone into this method. And also, is there an expiry date, or how long is the token valid for?
It's exactly. It'll be the same as
a normal script.
Yep.
Fantastic.
Yep.
And we've had a few congratulation messages for you.
No,
so well done on all your hard work in the e-prescribing space.
It's as much politics as anything, I tell you. God. Next thing, I will nag you about health pathways, because all that information on the website is actually on there. That's why, because we get a lot of emails afterwards. Could you please send us the email with the website? The websites are on there, so COVID information is actually it's already on there. The other thing was, look, I will end with this again, because I know we've seen like we're nagging today about this testing everybody. I put a press release out because, frankly, we're really worried about this, and the worry is at two ends. The first thing is really patients actually not getting it. We're in a COVID world now. There is a new normal. And the new normal is that if you've got any symptoms at all, scratchy throat, runny nose, you got to go get tested. And our problem is that we are getting people turning up to pharmacies with a scratchy throat asking for lozenges. And I've had 3 patients come through to me, despite our things on the website, our signs on the front, and the receptionist asking about it, they just basically turn up and they said, oh, by the way, I've got a scratchy throat, but I didn't want to bother anybody with it. And they're so polite about it, and I love them to bits, but I'm thankful that they're at least a metre and a half away from me. And guess what? They're going to get a test as fast as you like. Everybody was masked up, but it's really, this whole new normal thing is a big thing. Now, this is a huge change for us because, I don't know, Louise, it's about 10% of people have some respiratory symptom at any given time.
10-15.
That is just a frightening number. That means 10%, 15% of people should not be going to work, should not be going out, they should be getting a test, and that's like massive. So I think this new normal idea in this post-COVID world is really important, because that's, and understand that's how we're going to stop the next wave. I mean, that's first line is that patients need to understand it. The other thing to put in mind is that we do have a problem at the doctor end a little bit as well. And I suspect the loyal listeners here aren't the ones, but you need to test them. As soon as they've got it, you just don't ignore it just because they say it's mild. You've got to test them. Every single one of them has to be tested. And that's why we put out a press release and got in the media. I've done a lot of media on this. I've actually had some problems so far, worries about like surgeons, stories about surgeons, ignoring the, they've got a bit of a sniffle, but we'll still go with the surgery. That's just not on anymore. This is a post-COVID, this is a COVID world, and we've just got to actually change our thinking about this. So yeah, it sounds like I'm nagging, but like I just couldn't summarize what has been said in this room anymore, that we've just got to do this. Test, and that's how we'll stop the next wave.
And I think keeping in mind that we do have all those testing options. We've got the SA Pathology testing, we've got the respiratory clinics, the COVID clinics, we've got ClinPath, ACL both having testing clinics. So it is really important to make sure that you do refer your patients on. I know it is very upsetting. I get so many emails around issues with PPE, wanting to test, wanting to examine your patients, and you just can't do it because of the PPE and the gown shortage. But it is so important that you do refer your patients on. And even if they say, oh, I don't think I need to be tested, it's important that you then say to them, look, the evidence is that it is low risk, but it is so important from a public health perspective that you are tested. You cannot go and put others at risk and go back to work. You need to go and get tested and make sure that you're safe and you keep everyone else safe. So it is really important that you do test. We've all said it tonight, haven't we? I don't think we can keep saying it anymore, that you've all got the message, and I know that you're all doing the right thing and referring people on, but it's just often helping the community to understand that as well when they see such low numbers out there.
I think it's about education. As much I realise now, it's about education, about the community, about the new paradigm that we're living in. And that's for us to be partly part of that and taking our responsibility, but really spreading the word. So nag, but that's what I've done a long time. So that's my job. Anyway, I'll leave that.
We're going a little bit over time tonight, but we're a little bit late starting, but I will just make a couple of things just to comment on some of the Q&A things and just to follow up as well on overseas travel, which is just seems to be a common question coming through, which is fair enough. I know your patients are asking this as well. Chris, you've been asked if you can do a TV ad on the issue. Chris, you're doing a great job, great news. So it's all positive comments coming in. And I think it is really important to try and get this through the media, isn't it, and out to the community, because we are seeing that relaxation happening there. So I just want to touch base on, there was a few questions that came through around overseas travel and how does that work. I don't know whether Sonali or Louise, you wanted to comment on overseas travellers and really the fact that we have incredibly few coming into SA, but we are just getting a few questions around what the process is for an exemption and how that might be granted. If you're happy to talk about that at all. I'm putting you on the spot there a bit, aren't I?
So yes, only unless you're a resident of Australia, it's still a lot of hard to get in. So things like compassionate reasons, like if someone, a parent is dying or something like that, is what the sort of exemptions that people can get. When we do get overseas travellers come in, they do get swabbed on arrival and then swabbed before they leave quarantine, so that we can detect any cases. But there is an exemption. You can apply for exemptions. I don't have the email. I'm sure you can send it around to Emily.
Yes, and I have sent it out before in my updates as well. That one you can apply for. Yep. And I can resend that out tomorrow as well, Louise, just so that's there so you can help your patients as well.
There are lots of questions from general public that exemption, they think that exemption means exemption from quarantine, which is not the case. It's still mandatory, and even if it depends on what exemption they're applying for, so that mandatory quarantine still applies to people, those who have been exempted to travel or come to South Australia.
And I think that is a really good point to emphasise, that although we do allow people to come in on compassionate grounds, that it's only then to go and see that particular person, or have to attend that funeral, to see that person for that end of life care in the last 2 weeks of the terminal illness. So it is keeping that in mind, that it's just a leave for that, and often there's very strict requirements around there in terms of if they're from overseas. I don't know, we've previously had police escorts, we've had all sorts of full PPE, and there's just incredible amount of detail and organisation that goes into these plans to keep the public safe. And I think that is really important, that we don't just let people walk off the plane and into a house. There's very strict requirements of how that's all managed. Spacing out on the plane, a row either side free. There's just so many logistics that happen in that space. But it is really a matter of all the states working together to ensure a really positive outcome. So thank you so much for everyone tonight for coming along, to all of our presenters, to Louise, Chris, Sonali, Jenni, Tom, and to Kate, Jane here at the RACGP. I hadn't done my RACGP plug for the night, so I had to put it in there. Thank you so much, Jane, from Adelaide PHN for hosting us here tonight. And we were really grateful to have Schwan with us here as well to talk through around the future of testing in this space, and I'm very happy to forward emails on to you as well. So if anyone wants to email me around that particular area around the genome and what this means for the future, I can forward that on through to the relevant channels because I cannot answer those questions. So thank you so much for joining us tonight, and we hope to see you in a fortnight.